Hello, followers of Neuro Takeaway. Welcome back to the channel. Today, we have the great privilege and honor to receive an outstanding neurosurgeon, rather a neuroscientist, because by means of his job, which is removing brain tumors from awake patients, he has a unique opportunity to study the brain in real time, in vivo, and he really takes advantage of this privilege. He basically defies the traditional localizationist approach to brain function, and he promotes connectomics and neuroplasticity view. And of course, I'm talking about Professor Hughes Duffau. Professor Duffau is the chairman of the neurosurgery department at Montpellier University Medical Center, and he is also the head of the INSEM team, plasticity of the central nervous system, human stem cells, and genetics at the Institute of Functional Genetics in Montpellier, France. He has written many books. He has published hundreds of papers, and he received many awards all around the world. But on top of this, he is considered a pioneer in the field of awake neurosurgery, and he is regarded as one of the guys that is revolutionizing the way we understand brain function today. So without further ado, let's go to the interview. Okay, that's right. Well, welcome back to the channel, Hugh. It's a real pleasure to have you here, and thank you for accepting the invitation.
Thank you very much for your invitation, for giving me also the opportunity to talk about my works these past 25 years.
Well, the first question is, what led you to dedicate yourself to performing awake surgery?
I had the chance to be trained simultaneously in cognitive neuroscience, functional imaging, and also as a neurosurgeon. So my goal was really since the beginning to try to both better understand brain processing as a fundamental neuroscientist and as a physician, of course, to try to be helpful for my patients, especially in the field of neuro-oncology. And as you know, patients with brain tumors would like two things. First, to live longer, and second, to improve, at least to preserve their quality of life. So very quickly, I understood that we had to make the synapse, the link, the bridge between both fields. And today, it seems to be an evidence between neuroscience and neurosurgery, but I can tell you that 20 to 25 years ago, it was not an evidence. And my goal was really to say, I will, first of all, better understand how the brain is processing thanks to the development advances in functional neuroimaging and neuroscience. But also I will use this knowledge in order to improve the quality of life and the survival of my patients by removing more tumor. But also I will try to adapt what I can see directly in vivo in patients to build new model of cognition and then to have a positive circle or even a spiral in order to continue to potentiate this link between different words, and not only neuroscience and neurosurgery, but also neurology, neuro-oncology, neuroradiology, neurophysiology, and so on. And finally, awake surgery was really a beautiful philosophy, if I can say, to be connected to the patients before, during, and after surgery, and to their brain in order really to better understand what they want really in order to preserve their quality of life and live longer.
How long have you been performing awake surgery?
for 25 years now.
25, wow. Well, and how did you combine the traditional, let's say, outdated localizationist model with the uh, direct electrostimulation effect that you get from your patients?
In fact, I did not combine because the problem is that it's incompatible. I mean, since the beginning, by trying to help these patients with brain tumors, and especially low-grade glioma, slow-growing tumor, in the vast majority of cases, they enjoy a normal life until the first seizures, and then we make the diagnosis. And I saw patients with very big tumor, I mean, a third of the hemisphere, located within so-called eloquent areas like Broca's area or Wernicke's area, and which are, according to localizationist principle, respectively the area of speech or area of understanding. And in fact, the patients were just in front of me without any a priori, and they were well. And so I said, it's not possible to continue to accept this model, which is totally incapable to explain the reality I have in front of me. And it was not just one or two patients, but hundreds of patients. So finally, this is the reason why I said probably mechanisms of reorganization occurred in the brain. Otherwise, you would be already aphasic or hemiplegic. You are not. And then we will go to the OR. We will do a mapping. So how your brain is processing, both at cortical and subcortical level. We will do awake surgery with intraoperative electrical stimulations. And we will adapt the resection according to your networks. And finally, that works because we were very empirical without any a priori model, but to try to change the model for each patient at the individual level. And this is the reason why, by accumulating all data based on 1,000 patients, we were really finally able to demonstrate that localizationism does not exist and was just a historical view of neurologists, but never the brain worked like this, fortunately for patients and for brain surgeons.
Okay, okay. You've introduced the concept of codeological framework uh, about brain processing. Could you elaborate a little bit on this concept, please?
In fact, it's a very old concept developed by Campbell, a psychiatrist from Australia, if my memories are good, 1 century ago. And he said to localizationist people, you wrong. Because in fact, what we have to see is not just one area corresponding to one function, but hodos plus topos from the Greek, topos location and hodos the pathways, the road. So it started, in fact, 1 century before the principle of the connectome to describe that many areas are interconnected, and finally, by creating networks, they were able to subserve different functions within the brain, and finally, by putting all functions all together, the principle of network of networks, so meta network, to have adapted behavior, complex behavior to the environment. And this is exactly the term initially we rehabilitated 15 years ago, but now we are moving to these new concepts of connectome, of meta network, in order to see that, of course, we have mosaics of cortical areas working all together, but we need to introduce the synchronization, the temporal synchronization between these areas, which are in fact at the level of both hemispheres. And of course, to understand these pathways, connecting them like this computer, if I cut suddenly the connectivity, of course, we will not be connected anymore. And this is exactly the same principle in the brain, except the fact that many colleagues understood that now, but they have a localizationist view of network, if I can say. I mean, the network of movement, the network of language, the network of spatial cognition, and so on. While if we are speaking about language, we need, in fact, interactions between subnetworks. For instance, now I'm talking to you, so I need speech, but I need, of course, also understanding. I'm doing movement, pragmatic of language. I need syntax, and I'm French people, I'm sorry about that, so my English is very poor. So we can understand that there is a discrepancy between what I want to tell, semantically speaking, and my grammar, and so on. So many networks just to speak about language. But language is not enough. I need also to have something to tell you which is beyond language, but what I did for 25 years. Otherwise, never you have decided to contact me. My emotional also processing, my personality, my history, and so on and so on. And when you start to put everything on together with executive functions, namely, if I continue to speak about my poor English, I have to concentrate a little bit, of course, on my English, in comparison with exactly the same concept in my native language. So that means that I'm building now transitorily a specific meta network by taking a part of each networks, themselves constituted by different subnetworks, themselves constituted by so many cortical areas connected all together, in order just to answer your question, and I hope for people to understand what I mean. So you see that definitely one area corresponding of one function. You don't need to be a medical doctor or neuroscientist to understand that it's not the truth.
And this is changing all the time, or there is no equilibrium there, no?
Definitely. You're totally right, explaining why I spoke about transitory meta-network. In fact, the brain is really a perpetual succession of new equilibrium state in order definitely to adapt to the environment, which is itself changing all the time. I mean, 10 minutes before to be connected, I did something totally different with my patients. After this connection, I will do something totally different with colleagues in a meeting, and so on and so on. So that means that each time we need this mental flexibility in order to adapt to not new rules, but new demand. And of course, this is the reason why we have really to be very flexible from one moment to another one. Plus what is not planned. For instance, if I had an alarm now, you can also perceive the alarm by yourself, which is not language, but meaning maybe there is fire in my hospital. So of course I will tell you, I'm sorry, but I will interrupt the connection because I have to check if there is fire or if it's just a problem of the alarm itself, a technological issues, and to act accordingly. So you see that in fact, how do you want to say, I have my network and I will continue to use them as if it was automatism, which is simply not possible if we would like to provide the best. On the other hand, we have the choice also to modulate this meta network. And I know many human beings in their life who are not pushing them, who are not creative, who are not critical, who do not want, for many reasons, in the vast majority because of comfort, to go beyond automatism. And finally, of course, they are not using the same potential of the brain if you are not pushing yourself beyond what you could do every day without thinking too much. And this is the principle of learning, of free will, and why not the principle of behavior, personality, and to be yourself.
And turning to surgery, what do you pity more, to sacrificing a strip of eloquent cortex, or sacrificing a white matter tract, an eloquent white matter tract?
Based definitely on 1,000 patients operated on in awake condition, and of course with the post-operative cognitive examination and the follow-up. In other words, if the patient were hemiplegic, aphasic, we cannot hide that, but in 99% of cases they are not. That means that we were able to build some individual and finally probabilistic maps of neuroplasticity. In other words, is the brain really homogeneous if you have a brain damage and if you remove a part of the brain? Or have you some areas which are more able to be compensated and other areas not so compensable? And definitely we demonstrated, which was already intuitive based on the classical literature. In other words, if you have a stroke at the level of the cortex, you have all chances to recover, at least to improve. If it's in the depth, you will be hemiplegic and you will remain hemiplegic for the next future. So we demonstrated that, of course, we are different, but in the brain, the cortex is much more plastic with a higher potential of compensation in comparison with the white matter tracts. Because if you cut the white matter tracts, I mean the surgeon, the tumor or stroke, then we have not to think that we are destroying 1 cc or 5 millimeters, but we are we induce a desynchronization of 2/3 of the hemisphere,
Right.
according to this principle of meta-network, odology, and so on. So that means that suddenly you have 1/3 of the hemisphere here still functional, 1/3 here, but in between you have no connection. And suddenly, of course, you have a higher risk to see a decrease of cognitive functions, but with the impossibility to perfectly recover. So definitely, to answer your question, we know that we have to be careful at the level of the cortex, which is not totally homogeneous, but we have this high plastic potential. In the depth, we have really to be careful like highways. Otherwise, if you cut them at the end of surgery, then we have a risk like I was on the road to see the traffic, which is totally disrupted and maybe permanently despite this dynamics of the brain, because of course, brain plasticity has some limitations. So be careful about the subcortical connectivity of the central nervous system.
It's an amazing concept. Um, does awake surgery imply less tumor resection?
Now, I like to say that this is the reverse, because for many colleagues, especially neurosurgeons, they felt 20 to 25 years ago when I started to awake the patient, especially for gliomas, that I will stop according to functional boundaries, which is the truth, but that the functional boundaries will prevent me to do extensive resection. And in fact, definitely, they have not understood just the evidence, the observation. If a patient with a big tumor in front of you as a normal life, that means that the brain already compensated before. And of course, we cannot understand that if we continue to believe on localizationism. If we forget the dogma of localizationism, and if you start to imagine the reorganization before your surgical act, this is the opposite. You will remove more, you will continue to push until you have encountered functional boundaries, but you increase the chance to remove finally more, especially within the so-called eloquent areas, because I spent my past 20 years to remove tumors not selected for surgery by other colleagues, not because they are good neurosurgeons, they can be more skilled than me, but because a priori they will say, oh, there is a tumor within Broca's area, I cannot remove it, otherwise the patient will be aphasic. While I reversed the concept, and thanks to the patient, I said, we will go to the OR, we will awake you, we will transitorily do the mapping thanks to stimulation, and of course, I induce a transitory disturbance. I will stop and I will just do a big biopsy, but in 95% of cases, it has been possible to remove more in patients, I reinsist, not selected for surgery. So that means that, of course, I changed radically their quality of life. And you can see the mix, according to your first question, between neuroscience, neurology, history, and neuro-oncology, because so many patients, even today in the world, are not selected for surgery because the weight of the history in neurology.
I've heard many people, I'm a neuroradiologist, and I've heard many people say Dufault doesn't like imaging for planning surgery. He doesn't use it. I would like to know your opinion. Is there a role for functional MRI or tractography in the planning of an awake neurosurgery?
Many people does not like nuance. And when I speak, I start by telling I had the chance to do a PhD when I was a student, and my mentor was Bernard Mazoyer, one of the founder of the human brain mapping meetings, dedicated to functional neuroimaging and DTI. So of course, I know very well fMRI and DTI. Of course, thanks to them, I built my own mental imagery since the beginning, as I told you, and I understood that localizationism does not exist. And of course, I love this concept of networks, which are visible thanks to fMRI DTI. But I know also the limitations, and they are visible because we have biostatisticians behind with, as you know, beautiful model. And thanks to this biomathematical model, you can use motion of water molecule, DTI, in order to build indirectly the pathways. But this is not the structure. And a fortiori, this is not the function. When I start to say that, it's not Dufault doesn't like a DTI, it's just the truth. This is a fact. And suddenly, people would like to believe on the fact that because they do not want to awake patients, I do not understand why, they will use DTI to compensate, but you cannot, because DTI, it's demonstrated just before, is not a function. So of course, I will continue to claim that fMRI DTI explained why so many patients from 5 continents came to Montpellier with the indication of non-selection for surgery, as I said, not only based on the localizationism dogma, but also based on preoperative fMRI DTI, which are not the truth. And in the doubt, the surgeon said, I cannot remove the tumor. And what I did is to remove the tumor against the results of preoperative fMRI and DTI. So definitely, I have the proof that this is not the truth. Mm-hmm. On the other hand, because, and the loop is looped and explaining why I spoke about nuance, we have probably the most extensive series here in Montpellier, where it's a small city, of patients operated on for a low-grade glioma with pre- and post-operative fMRI and DTI, hundreds of patients. Why? To better understand what I have induced by doing a lobectomy, to see how the patient recovered objectively thanks to post-operative cognitive rehabilitation, pre- and post-operative neuropsychological assessment, and of course to compare this, to combine, at least to correlate the neuropsychological scores to the fMRI and DTI, because non-invasive and with the possibility to do that longitudinally, why of course I cannot when I operate a patient. And when you combine everything, the preoperative status of the patient with fMRI, and then a first network already reorganized, otherwise the patient would be aphasic hemiplegic because the tumor grew for many months to many years. Intraoperative mapping with electrical preservation of the cortex and white matter tract, limitation of neuroplasticity. Postoperative transitory worsening, because it's not normal to remove a lobe or 2 to 3 lobes in the brain. then post-operative rehabilitation. But when the patient has this transitory worsening, we can do fMRI, especially resting state. And finally, once the patient recovered, and now many years later, when the tumor recurred, and when I did a second or even a third surgery 15 years later, so suddenly you have more than 10 years of serial investigation within the same patient is her own brain over years. And suddenly we have a unique opportunity to really understand how this plasticity works and what are the mechanisms explaining the map we published about limitation of reorganization potential of the brain. So my answer is just a tool, use it as a tool with good indications, and do not try to use it to compensate your lack of knowledge.
I think I get the idea. How would you like an MRI report of a tumor should be like?
An MRI before surgery, you mean?
Yeah. What do you need from the image?
What I need is really, for me, first of all, to calculate the growth of the tumor. So the volume, because I need to speak about, of course, the tumor, because this is my job. I mean
Of
to
course,
remove
yeah,
brain
yeah.
tumor. Otherwise, no reason to wake the patient and to do a lobectomy. I can
Sure.
not
Yeah.
do it in healthy volunteers. So my goal is, first of all, to see the tumor,
Yeah.
to calculate the volume, because the risk of malignant transformation and then the survival is related to the volume of the tumor. Everyone knows that in the field of neuro-oncology. And this is the reason why my goal is to decrease the volume of the tumor as much as I can, according to the principle of supratotal resection. Maybe we'll speak about that later.
Yeah.
And finally, to do a second MRI and to see the growth rate of the tumor. In other words, a tumor growing faster, as you know, as a radiologist, then the prognosis is worse, and the reverse is true.
Yeah.
Now, you put in this brain this tumor growing, and you can start to see the networks around, not to see exactly where are the fibers, where are the critical epicenters, because definitely fMRI and DTI are not reliable. When you combine with intraoperative MRI, you have approximately 80% of reliability. But it's just an insight to tell you the reorganization is much more around the tumor, or the reorganization before any treatment is much more in the contralateral hemisphere. Of course, if it's much more in the contralateral side, I increase the chance during surgery to remove more and to take margin around the tumor visible in preoperative MRI. If the areas are much more functional areas around the tumor, even if this is not the absolute truth regarding each activation area, but the pattern of reorganization. You have to be more careful by telling probably I will not take a margin, this tumor will regrow, and maybe I will have to push much more mechanisms of neuroplasticity after the first surgery by doing postoperative cognitive rehabilitation or by giving chemotherapy.
But for example, for that contralateral compensation, functional MRI may be useful at the beginning before the surgery, for example, for language, if you know that there is a bilateral control or not.
Yes, but I have nonetheless the habit to perform this kind of analysis after surgery, because in all cases, definitely if the patient is well in front of you, that means that he compensated. If he had seizures with a brain tumor, you should remove the tumor as much as you can. And because fMRI is not reliable at the individual level, you have to wake him. So why I will use it? In order definitely to predict if it will be possible after the first surgery to come back in a few years, or to give chemotherapy because invasion of the white matter tract. And at that time, I will say, this is the limitation of neuroplasticity. I can compare pre and post-operative MRI. Finally, I removed the vast majority of the tumor, but there is maybe 5% of residue within the minimal common brain, the white matter tracts. No reorganization at this level. I have seen a posteriori the fMRI before and after surgery, and despite the fact that you recover, finally, the mechanisms on your plasticity are very efficient at the level of the cortex, as I said, but not at the level of the subcortical pathways. So I had the regret to tell you that we will have to give you chemotherapy because I cannot reoperate you. Or the reverse, you have, after surgery, much more recruitment of the contralateral hemisphere. You have a residue within the cortex because at that time, the cortex was still eloquent, but you know that you can induce plasticity. And you started to say to the patient, I will have a chance to reoperate you. No chemo or radiotherapy now. And you see that this is a message also, which could be very important for neuro-oncologists if they knew mechanisms of neuroplasticity or connectomics. And my crusade is really, I say that to neuro-oncologists, you don't know brain processing. And you have, of course, to treat better tumor diffusing within the brain to better understand the dynamics of the networks of the brain. It's just common sense.
Yeah, yeah, I agree. Is there any gliomas for which awake neurosurgery wouldn't be indicated?
If unfortunately I meet a patient too late, I mean, if it was a high-grade glioma, the patient is already aphasic, hemiplegic. For people, of course, who will maybe listen this talk, the goal is not to say we can do what we want in the brain and in all cases, all patients will recover. What I can do is to preserve the function. In 99% of cases, the risk zero does not exist, as I said, but we have a very high level of reliability, and I'm sure you start to understand why, because we are preserving this connectivity. But if the patient already destroyed the pathways and is already aphasic, now it's just common sense. How do you want to ask to the patient, please be awake into the hour and help me by doing tasks, because they cannot do the task anymore because the pathways are already destroyed. So the question will be, can you restore the function? And today we have to be humble. The answer is not yet. I would like to, but in the next generations.
Okay. Besides the evident language and motor deficits, what are the most relevant disabilities that you see in your daily practice?
I will touch wood for more than 10 years or maybe 15 years. I did not induce any severe permanent aphasia and or hemiplegia. So that means that the patients are able to recover, which was not true when I started 25 years ago. The rate of severe permanent deficit was between 15 to 20%. Now it's less than 1%. So I was so happy when I was younger that I made a mistake. I neglected in my first 10 years the essence of human being, because I had patients in front of me. A priori, it was impossible to remove the tumor. Finally, I removed the tumor. Finally, they were not aphasic hemiplegic. I increased their median survival. Everything was perfect. And finally, no. Because when they return to a normal life, and because I continue to follow them, in the vast majority of cases, they told me after a few years, I can enjoy my life, I can move, speak, and so on, but I have some problems with cognitive functions. Typically what I described, speaking about the meta network, sustain attention, to be able to do 2 to 3 things simultaneously, to make a decision when you have many people in front of you instantaneously, to think about something else, to make judgment, to learn with a high level, not just, of course, who I am, but to play Rachmaninoff. and so on and so on. And second, they also told me, I have the feeling not to be completely myself. I changed a little bit my emotion, my mood, maybe my personality. And finally, I understood that it was not so complex to preserve language and movement, despite the fact that in vast majority of meetings today, neurosurgery, if colleagues are telling my patient is not aphasic hemiplegic, they did a great job, as I did 20 years ago. Today, I understood that it was not enough in order to be a human being. And then we started 15 years ago, approximately, to do extensive neurocognitive assessment, as I said, before and after surgery, but also regarding theory of mind. I mean, social cognition, empathy, mental flexibility, working memory, complex cognitive functions. And suddenly we started to understand that the tumor induced in more than 50% of cases some degrees of cognitive deficits, while the patient was not aware about that before any treatment. And finally, seizures, and finally, okay, we diagnosed the tumor. So I started to modulate my new model. Initially, remember, it was impossible to remove Broca's area. Finally, I did it. The patient were perfect and Broca's area does not exist. And finally, the truth is just in between, according to each patient and according to the reorganization of the brain over years. Because sometimes, of course, you can speak, but you can have some problems regarding higher cognitive functions. And then we started to introduce this new cognitive models into the OR by adding further tasks, including recently, 1 month ago, we published a task about self-evaluation. For instance, you are giving an answer into the operating theater during stimulation or not throughout the resection, and you have just in 4 seconds to say, this is a cat, for instance, if you have a picture of cat, and from 1, random, I don't know, to 6, I'm sure. And what could be very exciting also for us as neuroscientists is to see the patient telling this is a cat, while finally it was a dog, 6. So that means that not only the patient can speak, but he did not understand, but he was not able to self-evaluate by telling, to be honest, I don't know anymore, I made probably a mistake. So we can induce anosognosia, a problem of metacognition. I mean, the fact that we know what we know. We should be aware about that. Otherwise, how do you want to make a decision if you have many years or even 2 decades in front of you now by asking you this kind of very critical questions, even without any brain tumor? Is it for me the good moment to have a baby, to buy a house for the next future, to change my work, or to continue and to push and to have more responsibility? You see that as a human being, it's so complex to solve this kind of existential questions. It's a quest.
That has to do with that noetic consciousness. It is the same noetic consciousness.
Exactly. Definitely the fact that you should be aware about the semantic processing, environment. Definitely, if we cannot understand the signal by the environment, we will not be able to adapt. And speaking about ourselves, in other words, introspection, self-awareness. And typically, when I spoke 10 years ago about this new concept in neurosurgery, of course, nothing is new. A human being did not wait for me or for neuroscience in order to have this kind of quest in life. It was true 2,000 years ago with a philosopher in Greek, for instance, in Greece. But when I started to introduce this concept in the field of neurosurgery, they said, no, because you will leave too much tumor Dufault if you introduce too many tasks into the OR. But definitely, this is the negation of neuroplastic mechanisms. So definitely, you can remove more. And if you cannot remove everything in one surgery, please induce plasticity by doing postoperative cognitive rehabilitation, by pushing the patient to return to normal life, to continue to learn, especially if the patient is young. Very recently operated on a young girl who will go to the university now, so she will push, in essence, her plasticity, and then you will come back a few years later and you will remove more, because mechanisms of reorganization within the meta network we spoke about just before. And we can also introduce this higher cognitive and emotional level, namely, do you want to continue to be yourself? And of course, when patients are coming here, the first thing they're telling me, please remove the tumor, but preserve my quality of life and my personality.
Sometimes I wonder, is there in the brain any non-important, non-eloquent, redundant cortices or areas?
Yes, but at that time, very frequently, it's claimed that we use 5 or 10% of the brain. It depends. If you are looking at poor TV movies by eating popcorn, of course, you are using probably less than 1% of your brain. If you are doing complex surgery, you need, of course, to adapt each sequence to the environment, to the patient feedback, to your knowledge of the brain, but also to this patient at that time, to some problems which can occur related to neuropsychological issues, anesthesiological issues, and so on. So you see this perpetual succession of equilibrium state in my meta network as a neurosurgeon at that time. And I cannot tell you how much I can use my brain at that time, but not just 1% as when I watch TV. So that means that, of course, it depends on what we are doing. And definitely, if we would like to be critical for our brain, to push more, or just to live based on high-level automatism learned at school, or for cultural issues, and so on. So yes, definitely there are nonetheless some areas, especially at the level of the cortex, which can be compensated, because the proof is that I can do extensive lobectomies and that the patients are able to recover. But once again, do not see just before and after with a cavity or lesion of the brain. Introduce the dynamics, the oscillations within and between networks.
How far a supratotal resection should go?
I continue according to functional boundaries, as you have understood, in this brain, in this patient at that time, and it could change from one patient to another one, or within the same patient over years, because now I did in some patients 4 surgeries with 20 years of follow-up. And each time I can see that I pushed a little bit more. On the other hand, of course, it depends on the tasks we will introduce into the operating theater. If it's just moving and speaking, according to the previous discussion we had, you have a chance, of course, at that time to remove a little bit more. If you introduce cognitive and emotional tasks, maybe you will have to stop a little bit earlier, according to the wishes of the patient, according to the discussion we had before to go to the operating theater. What do you want to preserve in order to enjoy a perfect normal life with, of course, maybe 95% of the tumor removed and not 110%, we will come back. So you see that it's a balance, and we make the decision all together with the patient and the family before to go to the OR, which is just more or less a formality. The pre-planning is done like this. So my question is, how do you want to ask this kind of question to fMRI before surgery and DTI? Please, can you answer this question?
Is that what you call resection, the mapping à la carte?
Exactly. You know, I'm French, so we love to have a big chief speaking about good cuisine in France, or haute couture and not ready to wear. And we love to adapt to this beautiful quality of life according to not only the environment, but your needs. And probably this is a bias in my recruitment also, explaining why I have so many motivated patients. I mean, finally motivated human beings coming from 5 continents. Because in all cases, what they want is first of all to continue to be themselves, as I said. But it's not the same thing if you are a golfer, swimmer, or making sport with high level for bimanual coordination, or playing music, as I said, or if you are a mathematician, so you need to use calculation, while some people finally do not care to, they can use their iPhone and that's it to make a very simple subtraction or division. Or spatial cognition, if you are a dancer, I don't need it if I don't like to dance. And you can avoid any neglect, but not be able to dance like Nureyev, or and so on and so on. So you see that in fact, what means our quality of life according to our job, hobbies, lifestyle, and so on, or just to speak about language, I will not map 3 languages in a patient just able to speak French, for instance. It makes no sense. But if you speak different languages, and if you are translator, and if you tell me I need absolutely to continue to be able to translate from English to French, of course, into the OR, we will switch every 4 seconds from one language to another one. And of course, by switching, that means that you increase your executive functions and you will increase the cognitive demands, but not increasing the timing of surgery, because everything will be done simultaneously by the patient. So it's very, very demanding for 1 hour to 2 hours approximately.
And is there any limiting age for neuroplasticity?
Of course, it's classical, and that's true to say that when you become older and the potential of neuroplasticity is decreasing. That's true. But it does not mean that you have no potential of brain plasticity. An example, this year I operated on a patient 89-year-old, and I removed a tumor within the so-called Broca's area, and the patient is well. And not only able to speak, but also able to play piano and to learn new pieces. So that means that it's not just language, but also semantics, learning, and art. So you see that good news for everyone. Do not be dogmatic. Before 40, you can learn what you want. After 40 to 50, that's it. Not at all. Everything should be more flexible in our thoughts, fortunately.
Look, let me ask you a personal question. After so many years of stimulating and inhibiting the brain, do you believe in human soul?
As I told you, finally, for me, a soul is a mosaic of so many functions, making you unique as a human being. In other words, I believe in human personality, complex behavior, free will, creativity. But I cannot, of course, tell you I identify the area or even the network of soul simply because it does not exist.
Interesting. It's it's an issue. Well, the last question, I don't want to take you more time. What do you think, how do you envision a neurosurgeon of the future?
I started to give some parameters regarding the future of neurosurgery. To my opinion, I mean, the loop is looped. The first answer was, since the beginning, I decided I had the chance to be trained simultaneously in neuroscience, better understand neuroplasticity, connectome, brain networks, and so on, and neurosurgery, not only in order to help people, but to be active, not by giving drugs, but by doing brain surgery directly. Now, I think that we started really to change the model, the paradigm, underpinning what means neuroplasticity and brain networks. Definitely, I say that it was impossible to me to restore the function today. Why it was, to be honest, my goal initially. So maybe I have a risk to be a little bit frustrated in this life because I gave the opportunity to patients with brain tumor to live longer, 3 times more approximately, to live better, definitely a risk 20% now and less than 1%, but also to give new models of cognition based just on observation, because we are not so many to be connected to the real truth, to the brain of human being in vivo, as you said initially. If you put everything all together, I would like to give a kind of legacy to neurosurgeons, not just in order to reproduce what Duffau did, I mean to remove brain tumor within so-called eloquent areas like Broca's area. No, to go beyond by telling, of course, we have to continue to remove tumor until we will finally one day identify new molecules, and probably we will not have to remove a part of the brain. But in the meantime, to use this knowledge, not only to help people during my generation, but also to help other people to develop new models now interacting with neurosurgery, stimulation, for instance, but not to inhibit transitorily during a surgery to do mapping, but to potentiate neuroplasticity, like using transcranial magnetic stimulation, for instance, with rehabilitation, and to put the probe at the level of the good hubs in the good networks for these patients at a time, in order to modulate positively the network and to give all chances to this network to continue to compensate the function following a brain damages. In other words, really to build the restorative, functional restorative neurosurgery. And I continue really to believe, you spoke about believers, non-believers, that it could be possible and that it will be the next generations of neurosurgeons. This is the reason why the last paper I published was really to say to brain surgeons, please, since the beginning, try to be neuroscientists in order to learn simultaneously different fields. Why not also electrophysiology, neuroradiology? Why not neurogenetics or neuro-oncology if you would like to be dedicated a little bit more to brain tumor surgery? What you want, but to make a unique combination of different subnetworks, and then to create a pattern which will be helpful for the next generation. And definitely, we are not following a serial processing of the brain. I like to say, unfortunately, that I learned English too late. And this is the reason why I reached my limitation speaking about brain plasticity. I can continue to improve my English, to give many talks, to write many papers, to discuss with foreigners and so on. No, I reached my limitation because I learned too late. And my message is, if you would like to have something original, you need to build a unique synapse between different backgrounds. So it's better to learn these backgrounds since the beginning simultaneously, because the brain is processing in parallel and not serially, and then you will increase your chance suddenly to have a potentiation thanks to a transient meta network one day, allowing you to say at least one time in your life, Eureka. And at that time, you will be a real human being.
Awesome. I hope it will happen. Speaking about the future of neurosurgery, I think we will need neuroscientists, not just neurosurgeons. Um, Thank you very much, Hugh. It was an amazing interview. I'm sure our audience will be delighted. You have a lot of fans here in Argentina. And so I hope you can come to Argentina soon.
It will be my pleasure. I remember I had the chance to come once, and it's a very good memory because I enjoyed also a discussion, but potentiation thanks to music and especially tango, of course, and dance. And when you started to have a mosaic of different arts, suddenly you have the chance maybe to come back and to be in the plane and to say Eureka. So thank you so much for your
Thank
kind
you.
invitation, and continue to enjoy the beautiful country and the chance you have to potentiate different talents in different fields. And why not for you to also make a link between music, dance, um, research, neuroscience, and not just radiology, which is just a tool.
I hope so. Thank you very much.
Thank you so much. Goodbye.